Further ado, I'd like to introduce our first speaker, who is Professor Ming-Lung Yu and Ding Yu, also at University of Yat-sen University in Taiwan. So he is an expert and has led many trials and studies in treating liver diseases, especially hepatitis C, and he has also reported while treating hepatitis C and observed the changes in fatty liver. So we're very happy to have him to give us the talk. Professor Yu, please.
Thank you very much, Professor Ye, for your kind introduction. So let me show the presenting slides. And everyone see my slides?
Yes.
Oh, okay. So good day, my colleague, dear colleagues. Today my talk is the treating concomitant disease to mitigate the NASH. We all know that around 25% of the global population have a non-alcoholic fatty liver disease, defined as status greater than 5% of hepatocyte without any secondary cause of the fatty liver disease. Most of the patients with nephropathy will state it's pure steatosis or just only mild lobular inflammation. But around 30% of nephropathy patients will emerge to so-called non-alcoholic steatohepatitis, leading to advanced fibrosis, cirrhosis, and even hepatocellular carcinoma. Since nephropathy has become the major etiology of liver disease worldwide, so it's very important to prevent the disease progression in each of the stages. However, the most important cause of mortality among the NASH patients is cardiovascular disease. It is because that 80% of the patients with NASH will have at least one cardiometabolic comorbidity, including obesity, hyperlipidemia, hypertension, and type 2 diabetes. 40% of the patients will progress to hepatic fibrosis. And when compared to the patients of nephropathy without any fibrosis, the NASH significantly increase or cause mortality rate ratio with progressive fibrosis stage. The rate ratios was 1.6 in patients with fibrosis stage 1 and up to 6.4 in patients with liver cirrhosis. In this large scale study from the VA database, more than 271,000 patients with a mean 9 years of follow-up periods demonstrated that if the patient had any metabolic tracts, including the diabetes, hypertension, dyslipidemia, and obesity, they are all risk factors associated with the long-term outcome of end-stage liver disease, the liver cirrhosis, or hepatocellular carcinoma. And they also observe a statewide increase in the risk of hepatocellular carcinoma or cirrhosis with each additional metabolic trait. So since currently there are no any approved agents could be available in the treatment of NASH. So the question is that, does treating the concomitant disease could mitigate the NASH? The answer is yes. The lifestyle modification and bariatric surgery recommended to treat the obesity, diabetes, and cardiovascular disease could block all the stage from the His liver to NASH, and cirrhosis. And the use of GLP-1 receptor agonist and pioglitazole, which are approved for obesity and type 2 diabetes, could block the progress from the NAFR to NASH and the cirrhosis. So even in the absence of the approved agent for treatment of the NASH, we can also have a fourth strategy to approach our patient population with NASH to minimize the long-term adverse complication and to improve the long-term survival. The first one is the weight loss to control the obesity. The second strategy is to treat the type 2 diabetes and cardiovascular risk factors to reduce the cardiovascular events. And the third one is the off-label use of liver-directed treatment with vitamin E and paclitaxel to manage the NASH. And the final one is the agents that are potential could reduce the end-stage liver complications. And let's move to the first strategy to control the obesity. And obviously, the lifestyle modification is the diet and exercise is the first choice of the weight loss in the NASH patients. Because the second speaker, Dr. Kawaguchi, will focus on the exercise. I won't talk this topic here. I just move to the event of bariatric surgery and the anti-hyperglycemic agent that's approved to reduce the weight, the GLP-1 receptor agonist. This slide summarizes the impact of body weight loss on NAFLD. As you can see, with 3% of weight loss, we improve the steatosis. 5% of weight loss will improve the liver cell injury and inflammation. And if we can have a 77% reduction in the body weight, we can not only improve all the features of the NASH, but also can improve the fibrosis. And weight loss of more than 10%, we have more than half of the patients have a fibrosis improvement. Therefore, it's very important to have at least 7% of the weight loss to have the NASH improvement. So we followed 21 patients of morbid obesity in Taiwan who received the bariatric surgery and have a paired liver biopsy 1 year after the surgery. As you can see, along with the significant reduction in the body weight, there are also a dramatic improvement in the insulin resistance, the ST-LT level, and also the metabolic components. The histology also improved in the NASH score and the fibrosis stage. And so these two large-scale systemic review and meta-analysis demonstrate not only the bariatric surgery, but also the endoscopic bariatric and the metabolic therapy could improve the NASH, the NASH in the histology. A 2.39 improvement in the NAP activity score with the bariatric surgery, and then there were also a proportion of patients who will complete the resolution of steatosis, 66%, complete resolution of inflammation in 50% of patients, complete remission of fibrotic degeneration in 76%, and even fibrosis complete resolution in 40% of the patients. The GLP-1 receptor agonist has been approved in the treatment of diabetes, but because all of the GLP-1 receptor agonists could slow the gastric empty, decrease the appetite, and increase the postprandial fullness, so they have a great effect on the body weight reduction. As shown in this slide, there are dose-dependent manner in the weight reduction with the semaglutide 1 milligram per week, with an average 5 to 6 kilogram reduction or 15% weight reduction with 24 weeks of semaglutide. Therefore, we are curious that whether the GLP-1 receptor agonist could also have an effect on the resolution of NASH. The left side is the data from the liraglutide, the right side is the data from the semaglutide. The liraglutide 1.8 milligram per day, or the semaglutide 0.1 milligram, 0.2 milligram, or 0.4 milligram per week could have a remarkable improvement in the NASH histology. The primary outcome is NASH resolution without fibrosis worsening. The use of GLP-1 receptor agonist could have around 40 to 50% of the patient achieve the histology endpoint, compared to only around 10 to 15% in the placebo control. Another large-scale population-based retrospective cohort study with propensity score-matched patients with diabetes and cirrhosis demonstrate that the GLP-1 receptor agonist initiator had a significantly low rate of hepatic decompensation when compared to the DPP-4 inhibitor initiator or the patient with sulfonylurea. The low risk of decompensation include the ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, and hepatic encephalopathy. However, there are no difference in the hepatic decompensation risk between the GLP-1 receptor agonist and SGLT2 inhibitor user. So how about the effect of the SGLT2 inhibitor on the NAFE and the NASH and the NAFLD? This slide summarizes the study evaluated the effect of SGLT2 inhibitor on the NASH and NAFLD. As you can see, although the SGLT2 inhibitor could reduce the body weight significantly, but have a little effect on liver fat content. Therefore, currently there are no evidence that the SGLT2 could improve the NASH. The second stage is to treat the type 2 diabetes and the cardiovascular risk factor in terms of the control the hyperglycemia, hypertension, dyslipidemia, and smoking cessation to reduce the CV events. And alternatively, we might use the off-label use in the NASH treatment with vitamin E and pioglitazone. So when looking at the phase 3 large-scale phase 3 trial, 96 week of patients, 96 weeks of the vitamin E 800 IU per day or pioglitazone 30 milligram per day versus the placebo, you can see the primary outcome, 2 points or more improvement in NASH score without the worsening of fibrosis was achieved in 43% of patients with vitamin E, 34% of patients with pioglitazone, but only 19% in the placebo control. However, the use of vitamin E have a risk increased risk of mortality, hemorrhagic stroke, and prostatic cancer. And the use of pioglitazone might have the risk of increased body weight, fluid retention, and urinary bladder cancer and osteoporosis. This study tried to evaluate the long-term effect of pioglitazone 45 milligrams per day for 36 months. Again, you can see a significantly high proportion of the patients achieving 2 point or more reduction in NASH without a worsening of fibrosis in the pioglitazone treatment group, 58% compared to only 17% in the placebo control group. All of the NASH components was significantly improved in the pioglitazone group, but not in the fibrosis stage. Indicated the use of pioglitazone could improve the NASH activity, the steatosis, inflammation, ballooning, but cannot reduce the degree of fibrosis. We also interesting whether the effect of pioglitazone could be observed in Asia population, and conducted this double-blind randomized trial to treat the patient with 30 milligrams of pioglitazone for 6 months compared to the placebo. As you can see in the left side figure, there are 46% of patients achieve the NASH improvement compared to 11% in the placebo control, and 1/4 of the pioglitazone patients have NASH resolution compared to only 10%, 11% in the placebo control. During the treatment, there are a significant normalization, significant improvement in the ALT level, CRP level, and hormone index, but the improvement cannot be sustained after discontinuation of pioglitazone. Again, in the histology, you can see the pioglitazone could improve the steatosis, nausea, inflammation, but not the hepatocyte ballooning, and also not the fibrosis status. When looking at the safety profile, you can see the adverse events was comparable between the two groups, the pioglitazole and the placebo. And interestingly, we did not observe the body weight gains or the fluid retention in the pioglitazole patients, which was quite different from the study from the West countries. So how about the other category of anti-diabetic agents and the NAFLD? Here summarize the study results with metformin and DPP-4 inhibitors. You can see metformin and DPP-4 inhibitors have no effect on the liver fat content and the NASH. Finally, I will touch about the potentially the agent with potentially reduction of the end-stage liver complications. There are many animal model and in some small scale human cohort demonstrated that statin could reduce the risk of portal hypertension or reduce the degree of portal hypertension. The metformin, there are complete data on the HCC risk, especially in the patients with hepatic cirrhosis. So here I would like to share with you our experience in another story. We evaluated the patients, chronic hepatitis C patients who achieved viral eradication of the interferon-based therapy, and to look at whether the risk of HCC remain after HCV eradication, and to look at the risk of HCC. As you can see, the 5-year cumulative HCC risk incidence was 3% among the patients who achieve SVR and without type 2 diabetes. And the risk increased to 10.9% for the patients with diabetes and without the metformin use. And if the patient with diabetes and with metformin use, the risk of HCC could decrease to only 2.6% in 5 years. The multivariate analysis demonstrates there are 5 unfavorable risk factors for the HCC development of the viral eradication, including the diabetes without metformin use, the liver cirrhosis, age more than 65 years, male gender, and obesity. However, if the patient have hyperlipidemia and with statin use, the risk of HCC could be reduced. So our data implicated that in the patients eradicate the HCV, if the patient still at the risk of hepatocellular carcinoma using the metformin for diabetic patient and statin for hyperlipidemia patient could be as a chemo preventive agents for the HCV-related HCC after viral cure. So the 2022 ADA standard medical care for diabetes recommended the lifestyle intervention and the cardiovascular risk reduction for all the patients with NAFLD, whatever the disease spectrum. But for the patient with NASH, fibrosis 2 or 3 or cirrhosis, we might recommend the vitamin E to treat the NASH patients. And for the patient with diabetes and the fibrosis 2 or 3, pioglitazole and GLP-1 receptor agonists are recommended to reduce the risk of NASH and its long-term complication. And for the NASH cirrhotic patients diabetes, the evidence is still need to accumulate to use the GLP-1 receptor agonist to treat this special population. So in summary, there's still many unmet needs in the NASH management. Exploration of effective drug or NASH treatment is still very challenging. Treating comorbidities could mitigate the NASH and improve the long-term outcome of the patient with NASH. Significant weight reduction is the ultimate goal of NASH for the obese patients, and GLP-1 receptor agonists have the power to improve the NASH resolution without fibrosis worsening. And paclitaxel have been shown to improve the liver inflammation, reduce the liver fat, and mitigate the NASH, but cannot improve the fibrosis in NASH patients. It's very important to have regular medication to prevent the cardiovascular events in this patient population. So the results from the anti-diabetes drug and lifestyle modification open the new landscape of NASH management. People, the specific therapeutic agents targeting the NASH being proved. Thank you very much for listening.
Thank you very much, Professor Yu. So now this talk is open for question and answer and discussion. Are there any questions from the audience? If not, may I ask you a question, Professor Yu? So, yeah, thanks very much for the extensive review. And in your experience and your opinion, among the concomitant disease, which one is the most important to control NASH and for a better prognosis?
I think among the comorbidity, the most important one is obesity, because obesity is, I think, is the original of the insulin resistance, which responsible for the development of hypertension, diabetes. So to control the body weight is the most important way to manage our NASH patients. Even use the GLP-1 receptor agonist. The effect of this agent to control the NASH is through the weight reduction, and not only the GLP-1 receptor agonist itself. So I think to control the body weight is the most important way.
May I ask a question?
Sure.
I'm Dr. Amadori. Thank you very much for a very nice talk. And I really appreciate very much that you used, under the NAFLD, you used the NAFL, which is fatty liver, and then you speak about NASH. So, I mean, actually, I really don't know what makes, NAFL going into NASH. But if NASH means inflammation, what do you think about giving the people aspirin?
Yes, yes, there are one study, I think from the England is the Scotland. I think it's a large scale study that demonstrated that the aspirin use could reduce the overall risk of hepatocellular carcinoma irrespective of the etiology of the coronary liver disease, by the HBV, HCV, or non-Ming-Lung NASH and NAFLD. But in many other studies, if we put all the confounding factors together, the effect on aspirin usually did not exist anymore. So I think maybe we could have some anti-inflammatory effects, but using the NSAIDs, there are many large scale studies did not observe the effects in preventing the long-term complication of the liver.
Thank you.